Dr. Paul Scott for the physician like myself that implant devices perhaps focus mainly on the implantation device itself. More importantly, or even in terms of looking after the patient, is how best to program the device to make sure the patients receive appropriate therapy. And Paul is going to tell us the latest in this particular area. Paul.
Thank you. So the title of my talk is a bit of a mouthful. The 2018 HRS update on optimal ICD programming. What don't we know already? I have no significant conflicts. So I think the first thing, certainly uncertainty I had when giving the talk, is what I'm going to talk about as the updates coming this year rather than last year, so I'm not going to be able to talk about that. But given the theme of the title in terms of uncertainty and what we don't know, what I'm going to talk about is where the data is lacking or there is uncertainty, try to focus on this, or where there's been more data since the 2015 publication. In terms of structure, I'm going to spend the first 4 or 5 minutes talking about what we do know, what I think we know, and then what we know we don't know. So first on to what we know. So I think none of this is very contentious. The background to this talk is that most ICD shocks are not life-saving, but they are associated with mortality, morbidity, anxiety, and a reduction in quality of life. When you're treating a patient with an ICD, it's essential to try and reduce device therapy to the minimum necessary to prevent VT or VF-related mortality and morbidity. Although we often give drugs, and many of us like doing VT ablation, by a long way, the most effective approach to do this is good programming. So in the last 15 years, there have been a number of landmark studies that informed us the best way to program our devices, and these were summarised in the guidelines from 4 years ago. In terms of device programming, there are a number of distinct programmable aspects that we all know. In terms of detection of therapy, these are heart rate threshold, duration, use of discriminators, and then in terms of therapy, use of ATP and shocks. And in the next few slides, I'm going to talk about, I think, 3 of the areas where there's a little bit of uncertainty. Heart rate thresholds, duration, and use of ATP. So the use of a high detection zone in prophylactic devices, as we all know, was evaluated in Marit-Ritz, compared a zone of 170 versus 200, and in a randomised fashion of 500 patients in each group. And as you can see, and I'm sure you'll know, it reduced inappropriate therapy or time to first inappropriate therapy by around 80%, with an associated reduction in mortality of 55% and no significant increase in syncope. In terms of prolonging detection time, we put this together and it's published in Heart Rhythm 5 years ago. At that time, there were 4 controlled studies with contemporary control groups, 3 of them randomised, and nearly 5,000 patients. And if you prolong detection and let whatever it was self-terminate or stop happening, you reduced inappropriate shocks by 50%, appropriate ATP by 75%, inappropriate ATP by 65%, and mortality by 23%. So it's very effective. In terms of ATP, it was one randomised trial, pain-free 2. This is now, so 15 years ago it took place. It randomised ATP and shocks versus shocks only, and I'm sure you all know that it reduced anxiety and improved quality of life in the ATP arm, and ATP was successful in 72% of the time, terminating the arrhythmias. So the recommended guidelines in terms of Class 1 recommendations made a number of statements. It suggested for primary and secondary prevention patients you should use a long detection or prolonged detection, 30 out of 40 or 6 to 12 seconds or equivalent. And for prophylactic devices, you should program a lower rate of between 185 and 200. All of these Class 1 recommendations. And you should use ATP up to 230 beats a minute in structural heart disease. We put this together in 2013, our programming protocol at King's, based on largely my experience as a fellow in Canada, using detection times 30 out of 40 or equivalent, and a lower zone of 200 beats a minute for prophylactic devices and in VF. And we found that by instituting the protocol, we reduced inappropriate therapy by 86% compared to before and after, with a reduction in any therapy. So it was very effective, and we didn't see any increase in syncope in the patients we looked at. So up till now, you could summarise it by saying a number of studies have shown us the best way to program devices. They're summarised in the guidelines, and if you follow the guidelines, you get good results, as we did at King's. So what is there that we don't know, and where is the uncertainty? I'm now going to spend a few slides looking at this. So the first thing is in terms of detection heart rate. So there's only one randomised trial that looks at this, MAD-IT. However, it doesn't just look at the heart rate difference. As you can see here, the high rate arm also had a longer delay in the active arm. So it's biased, there's only one study and it's biased slightly. It's 2.5 second delay versus 1 second delay. We know that longer delay improves outcomes. So there's only one study, it's slightly biased towards the higher rate doing better anyway because of the long detection. But what about a rate above 200 beats a minute? Well, one French group have been programming the devices, the prophylactic device, with a lower rate of 220. And I think they've published twice on this. This is the largest publication, the most recent one, where they compare 500 patients programmed with a low rate of 220 and treating nothing below versus two other groups, a standard guideline-based 200 beats a minute and one at 177 beats a minute. And you can see from the top figure that any therapy rate is much lower if you program the device with a low rate of 220 versus either of the other two approaches. And there was no increase in mortality. So I think in terms of detection rate, what we don't know, there's not much data on the best cutoff in primary prevention. There's nothing in secondary prevention. There's likely to be a sweet spot that may vary depending on the indication, and a higher rate may be advantageous, but there's no randomised data to back this up. So what about detection time? Well, there's a lot more data here, and I presented 5,000 patients. But what about secondary prevention? Because the guidelines suggest a class 1 indication to have long detection in secondary prevention. So at a rough estimate, the number of devices implanted in the US per year currently is around 100,000 plus. A large portion, probably minority, but a large number of these are secondary prevention. The number of patients programmed with long detection in a randomised trial contributing to the guidelines with class 1 recommendation was only 229. There's a real mismatch between the number of patients that have provided the evidence and the number of devices of implants. And this was not a study in itself, this was a sub-study of Advanced 3. There's been more data since then. Pain-free SST, with Larry Stearns as the first author, published 3 years ago, and this was a Medtronic sponsored trial. Standard 18/24 versus 30/40 in terms of detection. Nothing else was much different, and they demonstrated it was safe in terms of syncope, prolonging detection in secondary prevention patients, 700 patients, and there's a trend towards improved mortality, but it wasn't significant. So there's now more data about secondary prevention devices. What about longer detection? So there's one study, Enhanced ICD, that looks at the use of 6 out of 80, so essentially doubling the detection time. They enrolled, this was non-randomised, they enrolled 60 patients, half of which were prophylactic devices. There were 7 VT episodes that went on longer than 30 out of 40 but terminated before 60 out of 80. Only one of these caused syncope. Their 12-month all-cause therapy-free rates improved by 3% to 93%. So it shaved off a few more non-life-threatening arrhythmias, and the 12-month syncope rate was 1.7%, which is pretty low, and only one of these VT episodes resulted in syncope. So, looking at what we don't know in terms of detection time, there's more data. There's lots of data on prophylactic devices. There's more data on secondary prevention, but they're still very underrepresented. And again, there's likely to be a sweet spot for detection time, that it may not be as per guideline. It may be longer than we currently use. There may be benefit from further prolonging detection time, but I think it's uncertain. So what about ATP? Well, it's important to note that ATP was not used in the two probably largest randomised trials that we used to guide who we put ICDs in, SCAD-HEFT, and it was not mandated in MAD-IT2. The only randomised trial, Pain-free 2, was pretty convincing. ATP success was 72%, but detection time was short. And if you prolong detection time by 30 out of 40 compared to how it was programmed in Pain-free 2, you'd expect a 75% reduction or 75% reduction in appropriate ATP. So it's very likely that ATP was claiming success for self-terminating arrhythmias, and it's very likely to be much less successful than the headline suggests. Furthermore, in MAD-IT, inappropriate ATP was associated with mortality, 3-fold increase if you had an inappropriate ATP. So I think, although I use ATP, and I program it on in my devices, I think it's fair to say that the value of ATP is not completely certain based on the evidence we have. And certainly Boston seem to think that. There's an ongoing large randomised trial of PAIS ATP. They plan to recruit 2,600 patients. And essentially it's similar to pain-free 2, but with longer detection. And this will give us a lot more data about the use of ATP. So another uncertainty relates to pre-existing ICDs. So for a lot of the centres in London, in the UK, if you have an old ICD service, many of your patients have pre-existing ICDs. But as far as I can see, none of them were included, or there were no patients with pre-existing ICDs included in the randomised trials at all. Fortunately, there's now more data. Pain-free SST, published 4 years ago. This was an observational study with Medtronic devices, nearly 3,000 patients programmed with optimal Medtronic programming. A third of these had a pre-existing ICD, and there appears to be no difference in outcomes between those that did and new implants. And the pain-free SST randomised trial of standard versus long detection for secondary prevention, half of patients had a pre-existing ICD, and they appear to do just as well. So there's now more evidence that you can program your older ICD recipients with new programming. So towards the end of the talk, we typically use generic programming to program our devices. So we use a programming approach that's been evaluated in a trial in one manufacturer, and we extrapolate it to another, partly because some of the manufacturers don't have randomised trials to guide us. This seems to work well broadly, but this paper or case series 2 years ago questioned this. They identified 10 patients where the device appeared to be functioning well, normally, but it didn't treat the VF appropriately. And 4 of these patients died, and a number more had rescue shocks and bystander CPR. And the authors suggest that generic programming, where they used an approach that was used in a randomised trial, but not in that device manufacturer, contributed to this. Clearly, this is only 10 cases, but it's of concern. So lastly, do we actually follow the guidelines, having some good guidelines and a good evidence base? And the answer is probably no. So this is an observational study using the Boston remote monitoring platform. It's in press now. And I think they looked at 250,000 patients in the US and looked at their programming of new devices and looked to see how that changed over time. They first looked at the use of the Manet RIT settings, arms, well, the long or high detection or both, and you can see from the left chart, arms B, C, or B or C. It doesn't really matter which you looked at. The penetrance of this programming for Boston devices was very low. Even 5 years after the study was published, only 10 to 20% maximally of patients were programmed appropriately. These are new implants. And if you look at what we were doing at King's and what most of you probably do in your own practice, using a delay of at least 6 seconds, so long detection, and a rate of at least 185 beats a minute for prophylactic devices. And they looked in the US at how many, and this is the green line at the bottom, how many devices were programmed appropriately. At the end of the study period, 2017, only around 10% of patients had a long detection and high detection zone. And it appears that the consensus document publication had virtually no impact on this, as the line is drawn when this was published, and it appears before and after there was very little difference. So, in conclusion, there have been significant advances in understanding how to optimally program our devices in the last 10 or 15 years. The consensus document, 2015, is clearly a step forwards, but I think uncertainty persists around many of the aspects of programming, and some may well be cleared up by the publication of the updates. But clearly, guidelines are only as good as your adherence to them, and certainly in the largest country implanting them, adherence is very, very poor. Thank you.
Thank you very much indeed, Paul. I think we'll take questions at the end, if that's okay. So.